right, let's get started. Good morning. How's it going? Okay, someone's pumped up. At least one person's doing fine, so that's great. So, reminder, quiz 2 closes tomorrow, right? So if you did quiz 1, you know the drill by now. So closes at 11:59 p.m., October 10th. That is tomorrow. It will cover lesson 4 and 5. So lesson 4, we did that last lecture. So that was section 19 and 20. And then we're going to cover 21 and 22 today. So keep in mind, lesson 5, you also have section 23. That won't be on the quiz. So that's the measuring brain structure and activity, the last section of that chapter. We'll save that for our last class on Tuesday. And I promise you, it won't be heavy content. So this means this is our last kind of full class together, which is a bit sad. Unit 1 flew by, and you guys were a good group. I wish I could continue on. Anyways, so you guys might be happy that I'm leaving. Okay, so yeah, Dr. Duffy is good, so don't worry. So 30 minutes, once again. Accommodations, go past your 30 minutes according to whatever you're approved for. Once again, you will be able to review your quiz once the deadline has passed. Some of you still are not sure how to re-access your quiz. If you go on our course Brightspace page, on the home page, there's a little link on the right side, upper right corner, that says frequently asked questions. If you click that, there is an answer there for how to review your quizzes, how to review your labs, and anything else related to kind of Brightspace stuff. So look at that. If you still can't figure it out, shoot me an email. I'll guide you through it. But yeah, you can review your quiz. You'll see what you got wrong. You'll see what you got right. Will you see the correct answer? No. That's your job to figure out where's the correct answer based on what you got wrong. If you can't figure it out, you contact me. I will go over some of the harder questions during our final class on Tuesday. So final class on Tuesday, we'll do a quick review of section 23. We'll do a summary table, the positives and the negatives of kind of each imaging technique. We'll go through that quickly. Then we'll do a quiz 2 review. And then I'll reveal the Neuron Art battle winners. Okay, keep in mind you have that you can submit. And then we'll just do a review class. Okay, so quiz 2. Reminder, only 4 to 6 quizzes count towards your final grade. Now, don't panic, right? You guys should be aware of this. Every time I show the next slide, people start freaking out, but you know it's coming. Exam 1 reminder. Yeah, exactly. So, reminder that exam 1 will take place October 15th. That's a Wednesday, right? Keep in mind, we do things a bit differently in this class. Your exam is not during class time. Okay, you're going to have your final class with me. We're going to end Unit 1 officially on Tuesday. Then Wednesday, you have the exam. The exam link will be available from 8 a.m. to 8 p.m., so you can start it at any time between that. And then once you start it, you have 80 minutes. So yes, if you do start it at 7:59 p.m., you're still going to get your 80 minutes. As long as you click Start Quiz or Start Exam, it's still going to say Start Quiz, actually, but anyways, for the exam. As long as you click it before 8, you're good, okay? The 80 minutes will still continue. You won't be blocked after 1 minute, for example. Okay? So, it's online. So, like you did your quizzes, it's going to be the exact same thing, okay? You enter a link, you're going to have a description. Once you're ready to go, you click Start, and then the questions will appear. So, once you start, you have 80 minutes to complete it. Accommodations is the same thing as we're doing for the quizzes. You can go past the 80 minutes based on how much time you're approved for. And there's 36 questions, okay? And the way we divide that is that we have 24 multiple choice questions, which are worth 0.5, and we have 12 multi-select questions, which are worth 1. So if you do the math, it gives you a score out of 24, and that's what the exam is worth, 24%. So this should really not be a surprise. So exam 1 covers from material from Unit 1, obviously. That's the only unit we did so far. So that's lesson 2 to 5. Lesson 1 was just kind of course orientation stuff. So this includes, right, keep in mind, you have 3 sources of content coming at you. The textbook, tricky topic videos, and the stuff we do in class. There's a lot of overlap between 3 of them. Sometimes one of them will say something that the other ones are not saying. It's all fair game, but if you see stuff repeating a lot, oh, it's in the text, oh, it's a tricky topic, oh, he spent 10 minutes in class, it's probably really important. Okay, so that's the way you should read through the learning objectives as you're studying. Okay, so the learning objectives that we really hammered on, you know that one's definitely an important one. So the breakdown will look something like this. You'll have 4 to 6 questions out of each kind of section we went through. So psychology and neuroscience, so section 1, 2, and 4, that was chapter 1. So really the only main content here is the fields. First off, you should know what psych and neuroscience is. You should know that we are a science, both of them. And then you should know the subdisciplines. That's really the only thing from chapter 1. Then we started talking about research designs, okay? How do you perform research within these fields? We talked about descriptive research and the various types that you can do in order to collect data. Then we went through correlational research, and we went to experimental research. Then measuring behavior. We actually did not cover this in class, but there is a good tricky topic video about it, and statistical measures, which I kind of gave you the breakdown based on the wave activity, what's important, what's not. But in terms of measuring behavior, just to make sure we update people that might not be following the tricky topics, you should watch all of them, of course. But who can kind of give me a summary of what are the types of measures you can use? Yeah?
The mode, the median, and...
Okay, you're talking about stats, the central tendency. Totally right. In order to project that, how can you collect the data? Yeah. Yeah? To get a p-value. Once again, how do you get that number, though? How do you get the data in order to do that? Survey. Okay, survey could be one. Survey would fall into what category of measuring behavior? Self-report, right? So you have self-report, you have report by others, okay, self-report, you doing your survey about yourself. Report by others, it would be like a parent reporting on the child or a teacher reporting on the child's behavior. Those are the common examples for report by others. You have behavioral measures, right? Watching behavior, marking down what's happening, having good operational definitions. Or it might be something more precise, like kinematics of a hand movement. So that's behavior that you're measuring with a specific number. Physiological measures, right? What could be a physiological measure? Brain imaging, exactly. Heart rate, all that stuff. And of course, you also have tests. So that's IQ tests and stuff like that, okay? So that's what the measuring behavior tricky topic is about. Since I'm not seeing a lot of hands, maybe not a lot of people watched it. Go ahead and rewatched it. That's fair game, right? Neuronal structure, that's what we did last time. Synaptic transmission, action potential, all the stuff we did last lecture. And today, cortical anatomy, and then measuring brain structure and activity, which will be on Tuesday. Okay, so that will be the exam 1 breakdown. Now, let's move on. So before we jump into brain structures, what do they do? Where are they located? All that good stuff. Let's situate ourselves and make sure we know how the neurons within those structures actually work to communicate with each other. So let's do a quick review. What are these things here? So scream it. I know you guys know. Thank you. Dendrites. What's this thing in the middle? Soma. What about this thing? Axon. This. Good. What about the little nodes here? Yeah, I like the pronunciation too. Good job, guys. Okay, so we know the neuron structure. That's pretty straightforward. You're going to do your art battle. You're going to have fun with that. Good. Now it's the tricky part, the signal, the synaptic transmission. So if there's neurotransmitters being released here from this neuron, what happens afterwards? What are we going to get? What are the dendrites are measuring here? Graded potentials, yes. So graded potentials, it can be 2 types. Excitatory. Okay, you're trying to create something towards a positive, or inhibitory. You don't want to excite it. So the soma here gathers all the information at once simultaneously from all the neurons connecting. So if there's enough activity, what number are we looking for here for something to happen? Negative 55 millivolts, okay? What's the resting again? Negative 70. Okay, so you're at negative 70 and you want to reach that negative 55. If there is enough graded potentials to reach that negative 55, what happens afterwards?
The sodium channels at the base of the axon opening.
Yes, exactly. So, and what are these type of channels?
They're voltage.
Voltage gated, and that's why they respond, right? Voltage gated. Change of voltage, it went past that minus 55 threshold. Okay, we're opening up. Sodium is coming in. Then what happens? Yes. Across, right? All across the axon, you have this. I think you guys said it before we went to the specific voltage-dependent channel. You get an action potential, right? And the action potential travels through, and travels through. Okay, so why does it only go one direction? Why, when you have an action potential, doesn't it go all over the place and backfires the other way? What's the mechanism behind that? Yeah. Which is, okay, yep, you're right, hyperpolarization, which is caused by what? Potassium channels are still open when the sodiums are closing. So that actually brings it hyperpolarized, and it prevents it from having another action potential in that segment, so the signal moves in one direction. Excellent. Okay, great. So you have that action potential successfully coming through. Then what happens? Go for it. Opens voltage-gated calcium channels. And when the calcium channels creeps into those terminals, what will happen after? Yeah?
The synaptic vesicle creates the synaptic connections.
Yeah, so the synaptic vesicles, once it detects that calcium, so what's the process of doing that? The vesicles kind of collapsing and releasing the neurotransmitter. Yeah? Exocytosis, you got it. Okay? So calcium channels open, action potential, boom, okay, calcium channels open, excitosis, then neurotransmitters come out, right? Is that clear? Okay, it's not that hard, right? Just break it down step by step by step. Obviously, each step has some precise chemical messaging happening, and we went through it last lecture. We have a slide for kind of each process. So just look at it globally, then if there's something that's not clear, just dive into it, clarify it, and move on. We're good? Okay, so now that we know our neuron structure, now that we know how synaptic transmission works, we essentially know how neurons communicate now, we're going to start looking at where these processes are actually taking place, what are the structures, and how do these different structures give rise to different behavior, different emotions, different in memory, you name it. So now we're going to tour the brain, essentially. So for today's prep, you had these two sections. So 21 was a very short section, parts of the nervous system, just breaks down all the types of nervous system. And then we dive into the brain kind of structures. So you had two tricky topics, cortical anatomy and cortical lateralization. So before we move on, we already saw the importance of myelin, right? So we know that this is the myelin sheet, okay? And I want to also make it clear what we mean by white matter versus gray matter. You guys probably heard that before. So look at this beautiful brain. That's me. Anyways, okay, so the gray stuff here, okay, all the contour, all the dark gray stuff, those are the cell bodies, okay? Those are these things all bunched together doing their processing all across the brain. And the white stuff you see connecting across different areas, within areas, across hemispheres, all the white stuff, this is where the axons are forming their connections, okay? So, obviously the myelin sheet is very important, right? Because it makes sure that the axon, which is the highway that sends the signal off to its neighboring neurons, it's well insulated and the signal goes through very efficiently. What happens when myelin is damaged? Well, it turns out you have a leaky signal, essentially. When you have a leaky signal, that's usually not good, okay? Because whatever you want to do, it's not done efficiently because there's something leaking out and it's not done in a way that you want to do it. And there are some health conditions that's exactly what happens, okay? The myelin sheet starts to deteriorate. So if you take MS, for example, multiple sclerosis, what happens with multiple sclerosis is that it's an autoimmune disease, okay? So your own immune system starts attacking, essentially, your own myelin sheet. And that's within the central nervous system. Okay, within the brain and the spinal cord, myelin starts to deteriorate. And then, of course, it's hard to propagate a signal. So MS, typical symptoms are muscle fatigue, tingling sensation, loss of coordination. So it all makes sense, right? So if you can't transmit the signal down to your muscles, okay, so you have the right command, that's all fine, but in terms of sending the signal down in order to make the movement or having the sensations come up, if you have some myelin sheets that are kind of deteriorating, it won't be a clean signal, right? So that's why you have these problems, these motor problems, these sensation problems. Okay, so MS, that's specifically in the central nervous system. You have another one called Guillain-Barré syndrome, which is called GBS for short. So in GBS, it's actually kind of the same symptoms as MS, okay? Some tingling, motor problems, coordination problem. But with GBS, what happens is that the myelin sheet in the peripheral nervous system is deteriorating, okay? So if you take a brain scan of someone with GBS, you won't see any kind of lines coming across here, versus MS, you would see that because we're looking at the brain. That's central. So MS, central, myelin deterioration, GBS, peripheral. And turns out you can actually dissociate both of them in a pretty simple behavioral task by knowing how the brain and the peripheral nervous system works. So it turns out if you do a reflex test, so let's say you do a simple knee-jerk test, someone with MS is actually going to have an exaggerated reflex, whereas someone with GBS is going to have a decreased reflex. So let's think about that. One is central nervous system stuff that's kind of deteriorating. The other one is peripheral. So the central nervous system, when you have a reflex happening, the brain sends down a signal to kind of calm down that reflex, right? The doctor does the reflex. As you're doing the reflex, the brain's going to realize you're reflexing, and it's going to stop the movement. You're not going to kick the doctor across the head, right? Well, it turns out if you have a leaky signal and you can't have enough inhibition coming through, your reflexes will be exaggerated. So that's the connection with the central nervous system. Stuff coming down to inhibit, it's not there anymore, exaggerated reflex. The other way, GBS, it's peripheral stuff, right? So not central, the stuff coming out of central. So if the signal can't even be created, essentially, you don't have anything happening. So it's a decreased reflex, right? Because the stuff that's needs to come into the nervous system, that's where the myelin is deteriorated. So you have a hard time creating the actual response, whereas the other one, it can come in, but in terms of controlling what's coming down afterwards, that's the issue. So that's just to distinguish the importance of the myelin and how you can have different health conditions. Depending on where it's targeted, you'll have different symptoms. Okay, so that was kind of my intro to break down the central nervous system and the peripheral nervous system. So hopefully by now it's clear that when we say central, we mean brain and spinal cord. When we're talking about peripheral nervous system, we're talking about all the nerves coming out. What is a nerve? Anyone want to try out? Yeah. Bundles of axons, exactly. So we know what an axon is, right? You know your neuron structure. When we describe nerves, it's essentially just a bunch of bundles of axons going through and kind of targeting the same place afterwards. So that's the peripheral nervous system. This is a very dumbed-down cartoon version. Keep in mind you have some cranial nerves coming out, if I can stop shaking here, there we go, coming out of the brain stem areas to control facial expressions and stuff going on in the face, right? Okay, so that's clear. So within the peripheral nervous system, you can break it down, okay? There's kind of two nervous systems within the peripheral nervous system. You have the somatic nervous system. So the somatic nervous system is what's responsible for your voluntary control of movement and for transmitting sensory information into your central nervous system. Okay, the fact I can see you guys, the fact that I can feel stuff, the fact that I have temperature coming in, that's all based on the somatic nervous system. And the fact that I can walk around and do voluntarily actions that I can decide upon, that's the somatic nervous system controlling all that stuff. Okay, so the stuff that you're consciously aware of, essentially, all goes through the somatic nervous system. Then you have the autonomic nervous system. So essentially, the autonomic nervous system controls internal organs and glands, and it's kind of considered outside of your realm of voluntarily control. So you can't really consciously trigger stuff from the autonomic nervous system, essentially. Okay, and we're going to further break down stuff here. Okay, so we have the somatic, doing actions, having sensations coming. We have autonomic nervous system. We know it controls stuff that we're not really aware of. So what do we mean by that? Well, you can further break it down into two other systems. So the sympathetic nervous system and the parasympathetic nervous system. So here's a little diagram that kind of shows you what each of them does. So if we're talking about the parasympathetic nervous system, that's essentially what's probably running in your nervous system right now, hopefully. Unless I'm stressing you out that much, maybe you're in the sympathetic area. I just showed you exam days and whatnot, so maybe you are there. If so, sorry. But parasympathetic, it's when you're relaxed, right? You're just there chilling. So what's happening? Obviously, it constricts the pupil, stimulates salivation, slows heart rate, stimulates digestion, and causes bladder to contract. Okay, so that's the parasympathetic. Just your body at rest. So let's say you're here, you're at rest, and you're feeling the sensation that, I have to go to the bathroom soon. And then out of nowhere, I point at you and I say, all right, come up here and describe us all the action potential stuff. What? Uh-oh, this comes in. Okay, so your sensation to go to the bathroom will soon be forgotten because that's not important anymore. You have a way more difficult task to kind of focus on, and your sympathetic system will rev up. You're going to panic a little bit. Are you ready to do it? Some of you will probably be motivated, and you'll do it fine. Some of you will panic and run away. Fight or flight, right? That's a sympathetic nervous system. You're going to fight it or you're going to flight it. And as you can see, it does the opposite of what I just described, right? Dilates pupil, inhibits salivation, increases heart rate, dilates the bronchi, inhibits digestion, inhibits contraction of bladder, okay? So fight or flight, when you're in a high-stress environment, it's not the time to be hungry, it's not the time to go to the bathroom, all that stuff is kind of diminished, and your sympathetic nervous system makes sure that other things are alert in order to kind of face the stressor. But keep in mind, the sympathetic nervous system, to be activated, it all comes down to a matter of how you perceive the threat, right? So what you perceive as a very stressful situation might not be a stressful situation for someone else. And that's where psychological factors come into play. Okay, so I think this is a good time to kind of get a good discussion going on. So now that you know the two systems for the parasympathetic versus the sympathetic, take a few minutes and think of a situation where your sympathetic nervous system was definitely activated. Okay? So think about it for a minute, then we'll get some answers so everyone can have other examples to kind of solidify that concept. Okay, so sympathetic, fight or flight stuff. Your body's responding to a stressor. Who has a good example? Who wants to start it off? Yeah?
After I did surgery, when I saw my knee for the first time.
So, sorry, can you quiet down a little bit? I know I said to talk, and then I'm saying to quiet down. Go ahead.
After knee surgery, when I saw my knee for the first time.
Oh, okay. After knee surgery, when you saw your knee for the first time, it was panic mode? Wow, okay. I could see that happening. Yep. Got hit by a car. Wow. I'm glad you recovered. Yes?
Roller coaster rides.
What's that?
Roller coaster rides.
Roller coaster rides. So you're in it, and then it's oh, wow, yeah, okay. Yep. First concussion in football. Concussions are interesting when it comes to revving a system. Yeah?
When I broke my arm.
Broke your arm? Panic mode? Yeah. So you get the point, right? Think about what you were kind of experiencing during that moment. And sometimes it's a false alarm, right? You might be sleeping, you hear a loud noise. Oh my God, is there a robber in my house? What's happening? Sympathetic, all ready to fight it off. And then you go there and it was just your cat knocking stuff down. Then parasympathetic kicks back in. Okay, I can relax. Okay, you get the point, right? Okay, so those are your nervous systems. Now we're going to dive into kind of brain anatomy stuff. So we're going to work our way up. So let's start with the hindbrain structures. So essentially what we're doing here, so this would be your spinal cord, right? Now we're at the first part that's considered the brain, which we call the brainstem. Okay, so the first part you hit on the brainstem is what we call the medulla. Medulla is a critical part to keep you alive, essentially. So what does the medulla do? So the neuron, so once again, when we're talking about structures, we're talking about clusters of neuron within that specific location doing a specific task for a specific function. But the signaling is always the same, right? What we just learned about synaptic transmission kind of happens everywhere. Now it's just a matter of what are they focusing on, what do they care about that specific group. So neurons in the medulla, they're responsible for regulation of heart rate. That's important. Respiration control, blood pressure regulation, and reflex actions. So like I said, for the peripheral nervous system, you do have cranial nerve. So obviously the spine stuff, it all branches out, controls your muscles and the glands of your body. But when it comes to the brainstem, you do have some cranial nerves coming out to control reflex actions, specifically in the face area. So what are we talking about medulla for reflex actions? We're talking about actions like coughing, sneezing, vomiting, swallowing, okay? So all these critical reflexes to keep you alive. The other day I was running and I swallowed a fly and then out of nowhere gagged automatically. I did not consciously say, oh no, this is gross, I have to spit it out. No, it just happened automatically. Thank you, medulla. Okay, so you get the point, right? So often we think, we take it for granted, right? Oh, breathing, heart rate, that's all stuff that's happening under the hood. It's still a brain process though. Okay? The brain is your central command center for all things. So if you go a little bit up, you reach the pons. Okay, the pons are an interesting structure. So the pons, obviously based on their location, and based on the name, pons, pont français, bridge, right? So essentially, what happens with the pons, because of where it's at, where it connects the spinal cord with the rest of the brain, it relays a lot of signals. Okay, a lot of signals go through the pons, whether it's from the cortical structures that are coming down, from the cerebellum to go back up. There's a lot of stuff being relayed across the pons. And the pons are also very important for sleep and arousal. They actually play a very key role in REM sleep. So you'll learn more about sleep stages in Unit 2. I've been foreshadowing a lot of Unit 2 stuff. But when you get into the sleep stuff, the pons actually do a critical role when you hit REM sleep. So what happens in REM sleep? So rapid eye movement sleep. What are you usually doing during that REM sleep period? Dreaming, yeah. So when you're dreaming, are you walking around sometimes? Are you doing actions? Yeah. Are you actually doing them? No. Thank your pons, okay? So when you get into REM sleep and you start kind of imagining all these scenarios and revving that motor cortex, doing these actions in your dreams, you're not actually physically doing them because the pons puts a stop to it. It does not go down the spinal cord, okay? So yeah, you can imagine all the actions you want from the motor cortex, all the motor areas. Nothing will come down though. You're sleeping. Pons know that. Okay, it's not time to act. Let him dream. Let him do his stuff in dreamland. It's not time to act out in the real world. Okay, so the pons are critical for that. Once again, a lot of facial and sensation motor control coming from the pons as well, because you do have some cranial nerves coming out, controlling facial expressions and whatnot. Is that a question up to there? Yep. I'll have to go there because I can't hear. I'm losing hearing more and more. Yep. Say that?
Like when you have nightmares?
Nightmares, yep.
When you move, does that mean like the signals go to your
Yeah, so essentially when you're having nightmares, a bear is chasing you or whatever it may be, you're running away as fast as you can. It's very vivid, it's very real within your mind, but you're not doing it. You're not running in your bed or running around in your house because of the pons. So the pons will put inhibition signal that stops that from coming down the spinal cord and activating the related muscles that you're actually using in your dream. Yeah. Yes? Cry? So it's probably not REM sleep. Yeah. And sometimes you twitch as well, right? So that's a different area where stuff still can appear and you're kind of in between sleep and awake sometimes. Because when you're like watching TV on the couch and you start passing out, you're half awake, half asleep, that's where you usually get that stuff. Yes?
So would sleepwalking be like because of like an issue in the pond, or is that again?
Yeah, sleepwalking depends what type of sleepwalking. It could be an issue with the pons. So back in the day, they did an experiment with, I believe it was cats. Yeah, it was cats. I'm seeing the video in my head again. Where they actually cut the pons, and they were walking around in their sleep, obviously. But sleepwalking as a condition, I believe it has nothing to do with the pons, though. I believe it has to do with not properly getting into REM sleep and not properly dissociating from sleep stage when you're awake. So you're like half awake, half asleep. Yeah. You're going to learn more about Unit 2. Good questions. Yep. Anything else before I move along here? Yeah.
When you're sleeping, is your sympathetic nervous system going off when you're like having a nightmare?
Yeah, it would. Yeah, because heart rate, right? Sometimes you wake up and your heart is beating. Yeah, that's the sympathetic effect. Yep. But once again, pons make sure that the sympathetic effect does not actually act out. Good? Pretty cool stuff, right? Okay, now you have this structure, cerebellum. Call it little brain. Fascinating structure, very fascinating structure. So the cerebellum, a lot of motor control stuff, coordinates balance and posture. One thing that cerebellum is very good at is in terms of learning a new skill. So it does a lot of error learning. So as you're learning a new complicated skill, you do a lot of errors, right? What the cerebellum will be doing in the background is comparing the action you did with the goal action and how far apart you are. And it will start calibrating. So picture yourself throwing darts, okay? You're trying to hit the bullseye. You might be far off from the left, far off from the right. The cerebellum will take all that motor control information and refine your program more and more as you practice more. So essentially, when you're learning a new skill, cerebellum is firing all out. But when you become an expertise and you learn the skill and you don't need much refinement, it's kind of permanent now, you don't use a lot of cerebellum. So you really see its role, right? So when you're learning something, heavily involved. Once you have that action nailed down, not as much involved. But very much involved with balance and control, posture control, all that good stuff. Okay? So obviously, spinal cord stuff comes in. Some of it goes directly to the cerebellum, even before reaching the cortex. Okay? So picture yourself in the wintertime, you're walking, and oh, it's a patch of ice, and you correct your posture without even thinking about it. That's spinal cord and cerebellum communicating with each other. Okay? Where's Mike? Oh, there we go. Okay. Just want to make sure I'm not forgetting anything. Okay, any questions about these three structures? Yeah.
So it's controlling the autonomic processes, like the breathing and heart rate, and it's also doing some automatic reflexes, right?
Yeah. Exactly. Yep. So a lot of projections will control heart rate. Some projections will control breathing. Some projections will go through vasodilation of blood vessels for blood pressure stuff. And then you also have the stuff that projects out near the throat area for reflexes. Coughing, gagging, sneezing, all that stuff. Yep. Excellent. Good questions. All right, let's move up. So now we have that was the hindbrain structures. If this could work, that would be nice. Okay. There we go. Now we're looking at the midbrain structures, and we're only going to touch on two kind of hot spots here. So we saw the hindbrain structures, which were here. Now we're going in the mid part of the brain, right? So midbrain structures, and there's two of them that we're going to focus on for this course, or that the textbook shows you anyway. So the substantia nigra and the ventral tegmental area. So these two areas have neurons that rely on dopamine. Okay, so a very hot spot for dopamine stuff. So if we look at the substantia nigra plays a key role, once again, in motor control stuff. So you're probably asking, why are you always using motor control examples? Well, to live is to move, essentially. So essentially what happens with the substantia nigra is that you have projections from motor cortex, okay? So you plan an action, motor cortex is going to figure out the motor program you need to do that action. But that's not the final thing. It goes through a bunch of other structures before hitting the spinal cord, including the substantia nigra. So let's say I want to do a grasping action, okay? So I have this cup here, and I want to do this successfully to pick it up and drink some water. So motor cortex and other motor areas will plan that action, but that plan is just a general plan. The general plan of go for a grasping action in that direction for that target. In terms of the specifics of the exact location, the exact force, and all that stuff, it's going to rely on other structures to clean that up. And the substantia nigra is one of them. Okay? So it's going to take the signal from motor cortex, it's going to refine it, it's going to take stuff from cerebellum as well, it's going to refine it, then it finally projects it down the spinal cord. And it can also kind of help shape the movement as you're doing the movement as well. Okay? So you have these dopaminergic neurons within the substantia nigra that will kind of excite the stuff that you actually want to unleash, that you actually need for the action, and the other stuff that might be part of the general program but you don't need for this specific action, it will leave out. Okay? So it really refines the movement. That's why we have these smooth, goal-directed actions that we can do. Now, let's say you have a problem with the substantia nigra, like Parkinson's disease, okay? So when we're talking about Parkinson's disease, we're talking about neurons in the dopamine that are dying off. Neurons in the substantia nigra, which rely on dopamine, that are kind of dying off. So if you don't have that connection, what happens with an action? You have a hard time starting it, and once you're doing the action, you have a hard time precisely doing the action you want, right? The specific Parkinson's tremors, that's why it's happening. Because the substantia nigra is not doing its job like it's doing for a healthy brain. And that's why you have these motor control problems of starting the movement, stopping the movement, and actually going towards the specific location of the movement. So very important structure when it comes to motor control. Now, the ventral tegmental area, you could call it the reward center of your brain if you wanted to. So now you see how neurons behave differently. So these are all neurons that rely on dopamine, but the substantia nigra neurons are going to focus on motor control stuff and coordinating all that stuff, whereas the ventral tegmental area neurons, it's all about making sure that if something is rewarding, we're going to release dopamine in your brain. Okay? And it's not a coincidence that they're right next to each other, because turns out when you do a successful skill, you want to reward it. If not, you wouldn't be able to do anything, because you would never be able to properly learn the correct action for it. So that makes sense. But it also plays an important role in all kinds of reward-related things. Okay? So you eat your chocolate cake, very rewarding, right? Blame this part. Okay? Dopamine coming out, hitting the frontal lobes. Then you acknowledge, this is good, this is rewarding, I want more, I want more, I want more. So you see where addiction comes, right? Drugs, once again, the drugs that are heavily relying on dopamine, so your cocaine, your methamphetamine, all that stuff, they essentially hijack the ventral tegmental area, okay? They make that rev up, it's a rewarding experience, feel good, etc. Okay, so those are two important structures within the midbrain. So obviously the ventral tegmental area, it's not just for actions, it's not just for rewarding stuff, but just to pair a reward signal with anything, right? Could be a memory, could be learning something new, could be an emotion, okay? So you come in front of the class and you start crying, and everyone's kind of hates you afterwards, you're annoying, we don't want to see that. That's not rewarding, you're not going to do that again. You come to class and you give a great lecture and everyone's like, oh, that's interesting, I really appreciate it. That's rewarding, you're going to do that again. Okay, so that's the ventral tegmental area projections with their dopamine stuff. Sounds good? Cool. Moving on. So now we're going to the surface of the forebrain. Okay, so we're going up. We were at the mid. Now we're looking at the whole cortex, essentially, and the surface of the forebrain. So let's get the terminology correct before we start kind of landscaping the different structures here. So when we talk about the gyri, which the singular would be gyrus, we're really talking about the raised edges and the folds on the surface, okay? Kind of the mountaintops of the brain, essentially, okay? So you see them pointing it out here. So these little lumps, that little lump, those big chunk here, those are all gyri that we call it. And then sulci, which the singular would be sulcus, these are the grooves and indentions between the gyri, okay? So gyri, think of mountaintops, big chunks all over the place, and then you have these indentions and kind of lines coming across, okay? So that's what we call the sulci, or the sulcus if you're referring to one. Now you have an example here of a very big sulcus, so the longitudinal fissure, that's that big kind of separation that separates the right and left hemisphere. So now you see another word, fissure. What does that mean? It's essentially just a deeper sulci, or a deeper sulcus in this case. Okay, so when you see fissure, it's essentially just a deep sulcus. When you see the gyrus, it means a specific part that's protruding out. And we'll use kind of these terms to kind of identify areas, right? So if you look here, you see the main brain areas, and you see how they're divided. So the central sulcus separates the frontal and the parietal. The lateral fissure separates the temporal from the parietal and the frontal. Okay, so you use these kind of as references to landmark your areas. Okay, so now we're looking at the anatomical divisions. Occipital lobe. Who wants to tell me what that does? Yeah. Primary visual cortex. So anything vision related starts there and will be projected. So if you want to kind of see an object and perceive it, it's going to happen here. Then eventually you're going to tag it with memory areas to make sure you recognize what the object is based on memory. If you're using vision for action, then it's going to come over here to eventually reach the motor cortex. But yeah, all vision stuff. And don't be deceived. It looks small, but if you would open the brain like this, it actually goes very deep in. Okay, so it's not that small. Okay, occipital, vision stuff, great. Parietal. Who wants to try parietal? Yeah.
Parietal is associated with the somatosensory.
Somatosensory cortex, the sensation stuff. Yeah, information about what's happening in terms of your body, essentially. Yep, that's a good way to put it. What about temporal lobe? Yeah.
Hearing, memory, emotion.
Yep, hearing, memory, motion, some aspects of language. I'm glad you said some aspects of language because we will see that in a few slides. And it all makes sense when you divide the language areas, why one would be in the temporal and one would be closer to the motor / frontal stuff. Yep, you got it. So temporal, usually auditory cortex is there, language stuff, memory stuff. Good. What about frontal? Yeah. Sorry, yeah, go ahead. No, go ahead.
I said
Thinking and decision making, right. So you guys saw a case where someone had severe damage to the frontal lobe in the textbook. Who wants to summarize that case quickly? Did you want to, since I was going for you, go ahead. So, okay, so Phineas Gage, right?
Yeah,
Phineas Gage, yeah, working on a railroad track.
And like a spike was like shot out of the railroad and it went right through his skull and it came through the prefrontal lobe. And
Yep.
It came out, I think it was through like the bottom of the parietal lobe.
Yep. Something like that. Yep, exactly.
And the doctor who helped treat him noticed that he could still function, like he could still walk and talk and like
Yes.
have like conversations, but his friends reported that he was having issues. He was acting out sporadically, like he was swearing. He didn't like abide by like normal social behaviors.
Yep.
And he survived, and he went on to like start like his own company in like Argentina.
Yeah, exactly.
He led a normal life, but like they observed like differences in social behaviors that helped people sort of like map what parts of the brain control.
Yeah, exactly. No, good summary, okay? So, unfortunate accident, gets a big friggin' rod up the skull, luckily survives, totally fine. Keep in mind, it only kind of damaged through the frontal lobes, right? So all the other things were working fine. But frontal lobes, we said decision making, impulse control. Turns out he had no longer impulse. He couldn't control his impulses anymore, okay? Phineas Gage was kind of typical kind of quiet dude. Then after that accident, was swearing a lot, et cetera, okay? So it changed, one would say it would change his personality a little bit because you don't have these impulse controls as much, and it changes who you are a little bit, right? So frontal lobe does a lot of impressive stuff when it comes to higher order planning and kind of inhibiting stuff and whatnot. Yeah?
So people with ADHD, does it affect their frontal lobe?
Does people with ADHD does it affect their frontal lobe? So yeah, so depends what specific case you're talking about, but when it comes to ADHD, yeah, you're right, it's an impulse control thing. Depending on what, like, I don't want to pigeonhole all the ADHD cases in one kind of category, because I know some of them, it's more of it's like a boredom issue. So it's not that you're hyper or whatnot, you're just kind of bored and you have to do something else, okay? Others, it is a kind of impulse control issue. So yeah, obviously very frontal lobe related. ADHD medication usually triggers what type of neurotransmitter usually? Dopamine, yeah, which there's a lot of dopamine stuff in the frontal. So there you go.
That would be related to why, I think you said, is meth one of the ones that affect
Yep.
dopamine? Because my dad has ADHD and he takes methylphenidate,
Mm-hmm.
which is a type of meth-related, but it's
Yep.
not like meth.
Yeah, same family.
ADHD medication. So it would stimulate that.
Exactly, yeah. And it's all about a threshold, right? So if the ADHD someone with ADHD, their threshold to kind of focus and whatnot might be very lower. So taking this will put them normal. Whereas someone who has a normal threshold and takes ADHD medication,
Yeah, they go all of them.
yeah, it's like, oh, I have to worry.
There's been cases of people who didn't know they had ADHD and like their friends are encouraging them to like try like a drug like
Yeah.
that. And they try it and they're just like
Calm,
I feel
calmer.
normal.
Yeah, exactly. So it's all about where your threshold is. And depending on where that is, the medication will affect you differently. So that's why there's an abuse of ADHD medication for people that don't need it, because it kind of gives them a rush. It's like taking meth, essentially. Yeah. Go ahead.
What about like Tourette's, like for like tics? Because sometimes like tics are different for different people with Tourette's. But like for example, like swearing.
Yeah.
I don't know.
Yeah, so Tourette's and tics about like continuing like a behavior that's you don't want to do, but it's on a constant loop. So that's a problem with, frontal areas with the motor connection. It's essentially just like a loop of that specific action that can't be inhibited for whatever specific reason. And I'm generally answering these questions in a very general sense, because guess what? I'm not an expert in that specific field. So I want to watch out. I don't want to lead you guys to the wrong way. But yeah, essentially it's a loop between whatever your tic is or whatever the thing that gets repeated a lot, and for some reason it just doesn't stop. And fascinating cases when you look at that. But once it would definitely be frontal lobe involved for sure. Yeah. All right, so we know the general anatomical divisions now. Now we also call functional divisions. Okay, so you have the anatomical divisions and you have functional divisions. Don't get mixed up, right? If I'm asking you a question on the exam that says something about anatomical divisions, don't go answering with these things, and vice versa. Okay, so know the difference. So we just looked at the anatomy, okay, depending on where it's located, close to the skull, so occipital lobe is close to the occipital area, all that good stuff. Now we're looking at three main functional divisions when it comes to organizing the brain. So one of them you can call kind of the primary sensory areas. So the primary sensory areas are essentially taking in sensations from the environment. So here you have your 5 main ones, there are other ones, and essentially the thalamus plays a key role. So the thalamus is essentially a deep brain structure, kind of right in the middle of the brain, actually, that all the senses, all the sensory information goes through, except one. Which one? Smell. Thank you. So, except this one, which will bypass the thalamus, everything else goes through the thalamus. So it's a signaling kind of structure. Okay, all the senses go there, and it kind of divides it. That's vision, go to occipital. That's sensation, go to parietal. That's auditory, go to temporal. Okay, so it just directs the traffic, essentially. And then eventually goes to the primary sensory areas. Okay, and that's where you feel, see, taste, all this type of stuff that you see in the environment. Yeah?
Minor question. What could cause someone to not have a sense of smell but have the other senses? I have a friend who she doesn't smell anything, but she can still get headaches from going into places that have a lot of smells, but she doesn't actually smell.
So that's probably toxins. I'm assuming that's causing the headache, maybe. I don't know. Can they taste?
Yes.
That's interesting.
So I don't know.
Well, essentially the smell. So the smell stuff doesn't pass the thalamus. So this case could be a healthy thalamus is there. You get all the other senses. But the olfactory bulb, which is where smell goes to. Okay, smell is so primitive, right? It was very useful when we first started to evolve. Okay, something is rotten, you want to avoid it. Something is good, you want to approach it. Basic stuff, right? So smell has its little olfactory bulb that we call, which does all the processing for smell and eventually sends it elsewhere in terms of what the memory is. So maybe there's some kind of disconnection there. Yeah. I'm not a neurologist, by the way, but I like the questions. Yeah.
Why are smell and taste so related if they go to different places?
Well, because turns out that the gustatory cortex, okay, where you taste stuff, is right next to the olfactory bulb. So they pair with each other very nicely. So that's why if you smell something that doesn't smell good, you don't have the impression that it's going to taste good, just because they're cross-communicating so much. Yeah. Yep. And you can trick, I think some do that with babies, right? They'll put something that smells good on their nose and then give them peas or something that they hate. Yeah. It's a good trick. Okay, so that's primary sensory areas, the areas of the brain that are responsible for taking in sensory information. Now you have the primary motor areas. So kind of same concept, but in order to get stuff out of the nervous system. Okay, so you have your primary motor areas that will use the brainstem, the spinal cord, in order to go ahead and trigger the right firing of the muscles you want to do for that specific action. Okay, so if I go and start putting electrodes and stimulating brain areas, if I start stimulating your primary sensory areas, okay, so if I start stimulating at the back here, occipital lobe, you're going to see stuff. You're going to start seeing flashes and whatnot, okay, because all the representations are there. So if you start stimulating it, you create the reality, essentially. You start stimulating where the hand is on the somatosensory cortex, you're going to start feeling a sensation on your hand, even if it's not there. Okay, you start to get the brain connection here. Motor area, same thing. Stimulate the area of the hand on the motor area, you're going to start twitching that hand, okay? If we're talking about the left hand, I would be stimulating the right. We'll get into that stuff. Okay, so primary motor areas, primary sensory areas. Now, the rest, we call it association cortex. And it's also called the silent cortex for the fact that I just mentioned about the other ones. If you start stimulating stuff here, you usually don't feel or you don't do anything. So association cortex is essentially everything else in the brain. So sensory and motor cortex, they're in each hemisphere. And the association cortex is essentially everything else around it. Okay, so let's dive into the motor and somatosensory cortex now. So, okay, well, before I dive into that, obviously association cortex, it's usually all the higher order planning stuff, the memory stuff, okay? All the stuff that makes you that much more intelligent than just the basic motor and sensory stuff. Okay, so motor and somatosensory cortex. So motor, the red strip, somatosensory cortex, the green strip, you have one in each hemisphere, and they're symmetrical. Okay, association cortex, you won't have that symmetry. It's parts all over the place, and they don't necessarily are not symmetrical, okay? So if we're looking at a part outside of the motor or the somatosensory cortex on the left side, doesn't mean that part on the right side does the same thing. It definitely doesn't, actually. Whereas motor and somatosensory, they're symmetrical. Okay, so what separates both? What's that little line here? Central sulcus, good job. Okay, so looking deep into the motor and the somatosensory cortex, you have these somatotopic maps, okay? So what we mean by these somatotopic maps is that there's a map within the line of the cortex that maps out the body parts, okay? And it's kind of equal to the way we're mapped out, roughly, okay? So starting with toes, going up, you have legs, then going up, you have arms, then face, then jaw, etc. So it kind of follows the way the body's organized. But as you'll notice, the amount of cortex dedicated to a body part is not related to the size of the body part. It's much more related to how much precision does that body part need to move or sense things, okay? So for example, fingers, right? We do a lot of fine motor coordination skills with fingers. It takes a lot of fine details, whereas leg movements, I don't have much options what I can do with my leg. Let's look at how it's represented in the motor cortex. So leg, oh, a little chunk here. Fingers, a big chunk here, okay? Legs are much bigger than fingers, so it's not about size. It's about motor control, okay? There's far less more precision in the fingers, so you have a bigger dedicated area on the cortex compared to the legs, for example. Okay, and you have the same thing for the somatosensory cortex. Are they identical, motor and somatosensory cortex? I'm seeing some no's, and you guys are right. They are not identical. Who can point me out something that's not identical in both of them and tell me why you think it's that way? Just to make sure we have a good understanding of what we're looking at here. Yeah. Teeth. Teeth and gums right here. If I go to the motor, oh, where is it? It's not there. Why is it not there? You can feel them, but you can't move them. Exactly. So why would you have a chunk of that in the motor cortex if you can't move them? You don't. That's why it's not there. Okay, so that's a good example. Genitals as well. So obviously a hot spot in the somatosensory cortex. Not much motor control there. You get the point, right? Yeah.
So does that mean that the motor cortex is only involved in intentional movement? It's in men, the genitals still moving, there's still nerves there. It's just not a conscious thing. So does that mean that the motor cortex is only involved in conscious?
No, because walking, for example, saying that I want to walk, yeah, that's conscious. But as I'm starting to walk, then it's kind of just on a kind of automatic loop with the spinal cord. And what was your other, you said something else before that I missed. It was, so if motor control is only conscious.
If the motor cortex is only involved in conscious decision making, but it's not.
No, it's definitely involved in goal-directed decision, which is conscious, but it's also involved in all the other types of movement. Unless you're talking about reflexes, then it's not there. Yeah.
Oh, okay, that was my question.
Yeah, because reflexes would be just the spine. Afterwards, you would realize it would be oh, I just did that movement. That movement is my leg moving. Oh, I did that because it was a knee-jerk reflex.
That makes sense.
Yeah, so you're revving the motor cortex after the fact because you're just kind of experiencing the movement, but the movement itself is not produced there. Does that make sense? Yeah. Anything else? Yeah. It's the only thing. So, oops. When we're talking about this and this, we're talking about somatosensory cortex and motor cortex. So, aside from these two strips, everything else is association cortex. You got it. Okay, so we know how the brain maps out how you feel stuff, how you move stuff. This is where it gets very fascinating sometimes in neuroscience. So what happens for someone who's an unfortunate accident and lost their right hand, let's say. Okay, so they lose their right hand. There's no longer a right hand there. But there's a representation of the hand. The representation wasn't cut out, and the representation of the somatosensory cortex wasn't cut out either. So the hand is not physically there anymore, but these parts are craving something. That's why you feel phantom limb pain. You got it. So you still feel that limb, which is not there. That's why we call it a phantom. But there's a sensation there. There's nothing there anymore, but you still get that sensation. And eventually, the brain, as we already discovered, or I already kind of dropped hints about, very plastic, okay, can adapt accordingly. So what happens is that the part of the hand will actually be taken over by the parts neighboring it. So essentially, the patient, with time, might feel their phantom going up towards their shoulder at some point, okay? I feel that hand pain, but it's on my shoulder. Why is that, doctor? Well, this is why, right? So the shoulder area is starting to take over the part that you're not using anymore. Some might even feel it on their face. Okay, there was a condition that I read about once. It was someone shaving, and it was feeling that they were shaving their hand, their phantom limb hand, the hand that's not there anymore. Why is that? Face area was taking over, right? Okay, so the brain is it's a fascinating thing to study because you have a lot of opportunity to kind of recreate stuff as you kind of adapt to whatever's happening to your body. Okay, so fascinating stuff. Okay, so speaking of brain-body connections, let's make sure we're all kind of aware of how stuff is contralaterally organized when it comes to sensory and motor stuff. So you have right and left here, okay? So you have a right hemisphere, you have a left hemisphere, you have a right half of your body, you have a left half of your body. Now if we take a look at the motor cortex, okay? Motor cortex, you want to use that to do actions, such as sprinting like they're doing. That would be all motor cortex stuff. So essentially what happens is that it's organized in a contralateral way. Contralateral. What does that mean? It means the opposite side. Okay? So I'm waving at you with my right hand. Which motor cortex is doing that? Left, you got it. Okay? So whatever you're controlling from the right will come from the left motor cortex. Whatever you're controlling on the left will come from the right motor cortex. Okay, somatosensory cortex, same thing. But keep in mind, here we're talking about stuff controlling, coming out. Now we're going to talk about stuff coming in. Okay, so feeling the sense of touch, for example. Left side will go to the right somatosensory cortex. So anything you're feeling on your left goes to the right. Anything you feel on the right side will go to the left side. Okay, so contralateral. And as I already described, they're symmetrical, right? So they're symmetrically organized. The only difference is that one side is for the right and one side is for the left, and it's contralateral. So whenever you're looking at a right brain stuff for motor or sensory, you know it's controlling the left or it's coming from the left. Yes? I'm going to go there. Just give me a second. Yes, go ahead. Patients that have stroke, yep.
Yeah, so is it like does it have to do with their brain? Or?
Yes. So a stroke, essentially, let's say I have a stroke on my left motor cortex near the hand area. I have a very hard time controlling my right hand, right? What if it's the opposite? Someone has a stroke in their right motor cortex near the hand area, have a hard time controlling the left hand. Get it? Awesome. Okay? So now we know about the contralateral stuff, and we know about the motor and so much of the sensory cortex. Now we're going to start looking at the association cortex. And the association cortex, it's usually structures that are lateralized. What does lateralized means? It means that it's only on one side of either hemisphere. So when we're talking about language areas are lateralized to the left side for most of us. Unless you're a left-hander, it could be on the right. But most left-hander, it's still on the left. So most of us, it's all on the left side. Okay, so language areas are all lateralized on the left side. And when we're talking about language areas, you have Broca's area and Wernicke's area. So now that you know your neuroanatomy a little bit, So you know where this is located and you know where this is located. Can you guess what each one does? Who wants to try Broca? Yeah.
If that, I guess it crosses it. Okay, if it's damaged or someone can have issues with producing language and speech.
Producing language and speech. You got it. So actually producing language, talking. Okay, so if you have damage here, you have a hard time saying stuff. Okay, you can say simple words like the, here. It kind of sounds like that. You can't pronounce full words. And it makes sense because what's over here? It's the motor cortex. What do you do for speech production? You do a motor movement. So that's why the Broca's area is located right there. Wernicke's area, it's in the auditory cortex. I wonder what that one does. Go for it.
So it's for speech comprehension.
Speech comprehension. Speech perception is damaged. Exactly, you got it. So speech production, speech perception. If this is damaged, you can still talk, but you can't perceive other people talking to you. Whereas this one, you can perceive people talking to you, but you can't talk back. Okay, so two distinct structures that are obviously heavily related with each other. And that's lateralized to the left side for most people. But is it really just the left side, though? So that's one thing that I want you guys to be aware here. Sometimes we're really good at saying, like, that specific structure does that, but it's never isolated. Everything's connected. Okay? So even if we are saying that language is all left side, it's not totally accurate. So yeah, language production, language perception, definitely left side stuff. But when it comes to like understanding the emotional tone or the prosody of the tone, okay? If you're saying something, is it in a joking way? Are you serious? So all that stuff actually comes from the right side. So obviously everything's connected. How is that connected? So how can something on the left side where it's all the language stuff, how can you have relationship with the right side? Welcome to the corpus callosum. Okay, so the corpus callosum is essentially a bundle of around 200 million axons coming across the right and the left. So that's why the stuff that you have in the left and the stuff that you have in the right that are lateralized can still kind of communicate with each other. So yeah, you're hearing someone talk to you, obviously left side stuff. Are they joking? Are they serious? Corpus callosum is going to go recruit that right kind of area that will kind of decipher that, and then you'll have a full understanding of what that person is actually telling you. Okay, so you see where the corpus callosum is. Okay, so it connects the right and the left here. You see it across there, and then here you see it. I believe this is a sheep's brain, if I'm not mistaken. So you see it when you kind of bend the brain back. You see just a bunch of white matter stuff coming through. Remember white matter, right? All the axons, so just a bundle of axons going through to form the corpus callosum. So it's essentially the highway to send signals from the left to the right or the right to the left. What happens if you cut that? Ooh. So it turns out, old school neurosurgery, before we knew how to do things better, when someone had seizure issues, so let's say you had a seizure that was a focal point on the left side, and then it would full-blown and cross to the right side, a lot of neurosurgeons thought to kind of prevent you from having these great seizures, maybe we should just cut the corpus callosum. So then it won't spread to the other side. You'll only have it at one focal point. It will be a lot easier to manage. Do you want to add in here? I see your hand.
So one of the neurobiologists that's really renowned for this is Roger Sperry, who did...
Sperry, yeah.
Sperry, who did 15 patients in 1985.
Split brain?
Yeah, 1984 to 1985. It was insane.
Yeah, did you read texts about him? Or? Yeah, it's pretty fascinating, eh? They go into the details sometimes, too. It's pretty gross. Anyways, so these poor patients, they get their corpus callosum cut. So for some of them, it actually worked. The seizure stopped, okay, or it stopped spreading at least. But what happens is that the brain, the right side and the left side, can't communicate, okay? So in an experimental situation, you can actually isolate the right and the left brain, okay? So it turns out vision, okay, so if you stare at one spot, the stuff that's on the left visual field will be processed by the right occipital lobe, and the stuff in the right will be processed by the left occipital lobe, okay? So just like motor, just like somatosensory, vision is also contralateral, right? So you can do clever experiments to see how these patients kind of perceive the world without that right brain, left brain connection. So you sit them down and you make them stare at the center here, and then you either flash something on the right or you flash something on the left. So if you flash something on the right, like I said, the way vision works, it will go to the left. So here it says, they'll flash a word and they'll ask the participant to say the word. So they're flashing it on the right, it goes to the left. What did I say about language stuff? It's all on the left. No problem. Says face. Okay, cool. What happens if you flash that word on the right, though? On the left, sorry. You flash it on the left, now it's going to go to the right side. Right side does not have language production, does not have language perception. They don't know. Nothing. They see nothing. Okay? And then the experimenter says, okay, well, draw it. And they do it perfectly. They just can't access language because their corpus callosum is cut. They can't access the left brain. They're not seeing it. It's not here. It's only presented on the right, so it's isolated to the right brain. What's the word? No clue. Draw it. Does it perfectly. Then some of the original experiment, I think Speary probably did this, or who was the other one? I'm blanking out. Anyways, not important. Another way to do this is to actually put objects, okay? So let's say you put screwdriver as the word, no clue what it is, then you have a bunch of objects. Just randomly pick what you think the word was. They'll pick the screwdriver 100% of the time. So they can't access it. They say they don't see it. They can't pronounce it, but they can still identify it because right brain can still do that. Doesn't need language for that. Just need visions and memory representations of what an object is. But when it comes to describing it with a language, they can't do it anymore. No corpus callosum to help them out. Okay? So before we leave today, as we're getting close here, other areas of the brain, of the forebrain that are very important. Was there a hand back there? Sorry if I'm ignoring you. Was there a hand? No? Okay. So other brain structures that are important in the forebrain, so you have the hypothalamus, the amygdala, and the hippocampus. So the hippocampus, prime area for memory stuff, okay? Forming new explicit memories, memories for spatial navigation, coordinating new memories with old memories, all that good stuff. So very heavy memory hotspot. I think the text showed you a paragraph about HM, if I'm not mistaken. Unit 3, you're going to dive into HM a lot more, but essentially HM, once again, another patient with seizure issues, and in his case, the stuff that they cut out both of his hippocampus. And turns out patient HM could not form new explicit memories, okay? So you would come in, you would tell me your name, I would say, okay, hi, then I would come back, oh, who are you? Would not remember, okay? There was an experimenter that studied him for about 20 years, still didn't know who it was. But a fascinating thing, he could still learn new procedural skills. So he could still learn new motor skills. So you see, although I'm saying it's all memory stuff, there are other types of memories that go elsewhere that doesn't need the hippocampus as much. You'll see that much more in Unit 3. But essentially, hippocampus, very important for memory stuff. Amygdala, emotional center of the brain, okay, where emotional processing happens. Okay, is this a pleasant experience? Is this a scary experience? Is this happy, sad, etc.? That's all the amygdala's job. And then the hypothalamus is what essentially triggers the sympathetic response. Okay, so the hypothalamus is what kind of signals all the specific kind of chemical messaging and all the neurotransmitters and the hormones you need, the adrenaline and all that stuff. That's what's going to unleash that for the sympathetic. Yeah?
Let's say you want to live without any emotion at all. You would search for it with the emotion.
You could definitely still function. What would you probably still get emotions from frontal areas. Like if you're an adult and you learn stuff, so you have memories tagged that was a good memory. You might not feel it, but you'll still be able to identify it. But like the gut feeling of an emotion, you would probably not feel anymore.
That's probably a good thing, is it not?
To have it? No, definitely not, because then you would be a robot essentially, and you wouldn't be rewarded as much.
I see no problem with that.
Okay, well that's another world that we're probably going towards actually, which is scary. But anyways, but just to kind of touch on that point, there was this case where someone did, I don't know how much it was. Anyways, it was a horrific scene, did a shooting on top of a roof, started shooting people. And then there was a letter saying, please check my brain because this is not me, or something like that. I'm just paraphrasing here. They did an autopsy, and guess what? There was a huge tumor on the amygdala. So you see the relationship between brain structures and actual behavior and how you process stuff and whatnot. But the amygdala, some would probably argue what makes you human, to be honest. It's what makes you the joy of actually experiencing something, or the thrill of having a little bit afraid. Why do we watch horror movies? It's kind of fun, right? Yeah. Amygdala?
So when people like take depression medication, would that go to?
Not really. The depression, well, it will influence that because of serotonin stuff. So depression medication, essentially, it stops the reuptake of serotonin. Most of them. Some of them do different stuff. But most of them, what it does is that when you release serotonin, which is kind of the happy mood neurotransmitter, instead of doing the reuptake, it kind of lets more in the synaptic cleft so you can have more. So then hopefully it will make you feel more happy, make you feel less depressed and whatnot.
Anxiety medications do the same thing.
Anxiety medication does the exact same thing. You got it. So does it specifically target the amygdala? I don't think so, but it will definitely influence it. Because you have more serotonin, the amygdala should be more responsive to happy moments, essentially. Okay, so is it a coincidence that they're all chunked together? Not really. So keep in mind, you see something, okay? So let's say I see a snake on the ground here. Okay, I see a big snake. So hippocampus will be like, oh, that's dangerous. That's a venomous snake. Stay away from it. So that's going to trigger amygdala to be afraid. Okay, go away, run away. And then amygdala is going to trigger hypothalamus to do the sympathetic response. Okay? And that's where the perceived threat matters. Maybe you're not afraid of snake. Maybe to you that doesn't care. And it won't trigger fear emotion, and it won't trigger the sympathetic. Okay, so that's where it's important to put the psychological factors into play. Something that stresses you out might not stress someone out. And this system of kind of the sympathetic system, so obviously it was built back in our evolution when it was useful to kind of use it when tigers are chasing you or bears are chasing you, whatever it may be. But now what's happening, we're over-revving it for stupid stuff, right? Oh, this email pisses me off, and you get all frustrated and whatnot. It's like, chill. This is not what it was built for. It was built for high-stress, life-or-death situations. So always keep in mind when you're stressing out, am I going to die about this? Probably not. So chill out a little bit. Just focus on the task. Go with it with a more clear mind. Okay, a couple of questions, then we'll be done for today. Any questions about these before we move on? You guys have very curious questions today. That's very fun. You're putting me on the spot. It's kind of very fun. Yeah? What's that?
What's the relation between both of them?
Relations. Can you quiet down a little bit? No, we're almost done. Relationship between amygdala and hypothalamus. So as soon as you sense something stressful or fright, or you're afraid of something, or it's perceived as dangerous, the amygdala will kind of send a signal, which will kick in the hypothalamus to start the sympathetic response. So the fight or flight will start. And it's kind of all simultaneously. I say one triggers the other one. It kind of all happens at once, essentially. But that's why they're all connected, right? You see something, what's the memory of that? Is it good? Is it not good? Should I react? Should I not react? Amygdala will process that. If we need to, we trigger in the hypothalamus. Yeah. All right, couple of questions, then we will leave. We're almost at a long weekend here. No wonder you guys are excited. Okay, how does association cortex differ from primary motor and primary sensory areas? Okay? So here are your options. Read through them just quickly, and then we'll do our clapping. So how does association cortex differ from primary motor cortex and primary sensory areas? And this is a multiple choice. There's only one answer. So clap if you think A, association cortex makes up much smaller portion of the brain. Good. B, association cortex shows a symmetry of function between left and right hemispheres. C, association cortex shows symmetry of function between left and right hemisphere. D, association cortex receives direct input from sensory neurons. E, when association cortex is stimulated with an electrode, it triggers touch sensations and involuntary movements. Okay, so not a lot of claps, but some of you did clap for B, and that is the right answer. Okay, so B is the correct answer here. Okay, they're not symmetrical. It's not like motor and some other sensory stuff. They're just structures all over the place, lateralized, not related to each other. All right. Damage to which part of the brain would most likely be fatal? So A, so clap if you think it's A, hindbrain. B, forebrain. C, hippocampus. D, amygdala. E, Broca's. Okay, So most of you said A, hindbrain. Yeah, why? That's where the medulla is. That's where it makes you breathe, makes your heart rate, all that good stuff, all the stuff that keeps you alive. So if you have a stroke anywhere in the hindbrain, that's where stuff gets very kind of not that great, right? Because that's very, 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 very important area in terms of survival mechanisms. Which of the following are parts of the central nervous system? Select all that apply. Could be more than one answer here. Okay, which of the following is or are parts of the central nervous system? Clap if you think the parasympathetic nervous system. Clap if you think corpus callosum. Clap if you think the sympathetic nervous system. Clap if you think Schwann cells. Clap if you think spinal cord. Okay, correct answer is B and E. Okay, parasympathetic, sympathetic, peripheral stuff, Schwann cells. Those are the myelin sheaths of the peripheral, not the central. What are the central? Oligodendrocytes, I heard it, thank you. All right, as a result of head trauma, a man loses his ability to talk, but can still understand what people say. He has most likely suffered damage to which brain area? So can't talk, but can understand. A, cerebellum. B, Wernicke's. C, primary sensory cortex. D, amygdala. E, Broca's. Good job, you got it. Okay, very important. This could be useful for exam stuff or quiz stuff. I might show you a brain, and I'll ask you, is the part shown on that brain picture? Okay, so which image shows the, and I could select any part I want, and then you would have to decide. So I'm going to tell you a part, and clap if you think it's on the A, if it's on the A picture, if it's on the B picture, if it's on the C picture. Right hemisphere, A. B. Oh, come on, guys. This is supposed to be an easy one. Right hemisphere, that's that big chunk right here. Is it on A? Yes. Is it on B? Is it on C? Thank you. Wow. Okay, temporal lobe, A. Okay, B. C. You actually don't see it, okay? I won't give you an ambiguous one like that, but you actually don't see it, okay? That's still, temporal lobe would be under here, okay? What about occipital lobe, A? B? I guess you're counting this? Yeah. C? Okay. Cerebellum, A? B, C. No, you don't see cerebellum here. Okay, cerebellum is that big little brain here. See it on A, you see it here. You don't see it there, though. Okay, let's do another one. Hippocampus, A. B, C. It's not there at all. It's a deep, deep structure. The brain's not open enough. You can't see the hippocampus here. Okay, so watch out for these ones. Have a good day. Take care. Best of luck with quiz 2, and see you next Tuesday.